Hello friends, welcome to my YouTube channel. Today onwards I am studying question bank of all the subjects of NEET PG except anatomy and physiology. My target is to complete the entire module, that is 723 modules except anatomy and physiology. I am not studying that. So total there is 723 modules and I want to cover all the question bank. And also I want to revise the entire question bank for 2 to 3 times. So this is my new strategy.
Starting with Gynecology Module 1, the vulva includes mons veneris, labia majora, labia minora, clitoris, vestibule, vestibular bulb, and greater vestibular glands. The vulva is posteriorly related to the perineum. The triangular space bounded by clitoris, labia minora, and fourchette is the vestibule. It is present between the labia minora anteriorly and the introitus posteriorly. The posterior part of the vestibule between the fourchette and the vaginal introitus is called fossa navicularis. The vestibule has 4 openings. They are urethral opening, vaginal orifice opening, Bartholin's duct on either side, ducts of paraurethral glands. The round ligament terminates at the anterior end of the labia majora. The labia majora lie on either side of the vulva and join posteriorly to form the posterior commissure. The inner side is hairless. Labia majora are homologous to the scrotum in males. The labia majora and the mons veneris contain hair follicles, sebaceous glands, and also apocrine glands, that are modified sweat glands. The labia minora are 2 cutaneous folds between the labia majora. Anteriorly, they enclose the clitoris and unite with each other in front and behind the clitoris to form prepuce and frenulum respectively. The labia minora are homologous to the ventral aspect of the penis. The clitoris is a small erectile body lying in the anteriormost part of the vulva. The clitoris is homologous to glans penis. Next is a case. A patient presented to gynecology OPD with Bartholin cyst, which involves the Bartholin's gland. These glands are homologous to the male bulbourethral or Cooper glands. The ducts of Bartholin glands open in the groove between the hymen and the labia minora at approximately 5 and 7 o'clock positions. They are stimulated by sexual arousal. The glands contain columnar cells that secrete mucus with lubricant properties. Contraction of the bulbospongiosus muscle expresses gland secretions. Bartholin cyst occur due to the obstruction of the duct of the Bartholin gland by proteinaceous material or due to infection. Symptomatic or recurrent cyst may require marsupialization or gland excision. An infected Bartholin cyst can lead to an Bartholin's abscess. This requires surgical drainage. The pH of the vagina before puberty is 7. In adult females, the pH is acidic. Doderlin's bacilli, which is a lactobacillus species, are part of the normal vaginal flora. They produce lactic acid from glycogen in the vaginal epithelium and make the vaginal pH acidic. They are present in the newborns and disappear in 10 to 14 days. They reappear at puberty and disappear after menopause. Vaginal flora also includes microbes such as Clostridium welchi. Vaginal defense mechanisms are influenced by estrogen. In newborns, maternal estrogens maintain the defense mechanism for 10 to 14 days. After that, the levels wane. During puberty, the circulating estrogen maintains the defense mechanism. The pH is higher in the upper part of the vagina due to mixing with alkaline cervical mucus. From birth to 2 weeks, vaginal pH is 4 to 5. From 2 weeks to puberty, vaginal pH is more than 7. During puberty, vaginal pH is 4 to 4.5. During reproductive period, vaginal pH is 4 to 5. During pregnancy, vaginal pH is 3.8 to 4.1. During postmenopausal period, vaginal pH is more than 7. Bartholin's gland is present lateral to the vagina. The vagina is related to the following structures by anteriorly upper 1/3 of bladder and lower 2/3 of urethra, posteriorly by pouch of Douglas, ampulla of the rectum and perineal body, laterally by McEnroe's ligament levator ani and Bartholin's gland. Cribriform hymen has multiple small openings. Based on the shape of its opening, the hymen may be classified as annular hymen which has oval central opening, crescentric hymen which has semilunar central opening, vertical hymen which has vertical slit-like opening. In septate hymen there is two lateral openings partitioned by a bridge of hymenal tissue. In cribriform hymen there are multiple small openings. Other variants of the hymen include absence of hymen, which is a congenital deformity. Infantile hymen has small central linear opening. Imperforate hymen has no opening. In fimbriated variant of hymen, free margin has symmetrical indentations anteriorly. In ring or fringe-like hymen, a narrow ring of thick membrane is present all around the vaginal orifice. It can easily distend during sexual intercourse without rupturing the hymen. The hymen is lined by stratified squamous epithelium on both sides. The hymen is most commonly torn posterolaterally or posteriorly. It is replaced by tags after childbirth, which are called as carunculae myrtiformis. Next is Delancey's levels of support of genital organs. Level 1. Structures forming the support are the cardinal uterosacral ligament complex, which provides apical attachment of the uterus and vaginal vault to the bony sacrum. Consequence of damage in level 1 of support is uterine descent, vault descent and enterocele. Next is level 2. Lateral attachments provide support to the middle part of the vagina. The anterior vaginal wall is attached laterally to arcus tendinous fascia, pelvis, and the posterior vaginal wall, which is attached laterally to the fascia overlying the levator ani muscle. The consequence of damage in level 2 is cystocele and rectocele. Next is level 3. The urogenital diaphragm, that is the perineal muscles and perineal membrane, and the perineal body provide support to the lower part of the vagina. The consequence of damage in level 3 is urethrocoele, gaping introitus, and deficient perineum. Next case is a patient with uterine prolapse and urethrocoele has weakness in the superficial and deep perineal muscles. In the given case scenario, level 3 supports including the superficial and deep perineal muscles are lost. This causes urethrocoele. Delancey's levels of support are used to describe the supports of the genital organs. Anteflexion of the uterus is seen at the level of the internal os. Angle of anteversion is 90 degree. It is the angle between the cervix and vagina. Angle of anteflexion is 120 degree. It is the angle between cervix and uterus. The uterus normally lies in a position of anteversion and anteflexion. In the anteverted position, the external os is directed downwards and backwards. On vaginal examination, the fingers come in contact with the anterior lip of the cervix as it is the lowest part. When the uterus is retroverted, the cervix is directed downwards and forwards. The lowest part of the cervix becomes either the external os or its posterior lip. Next case is a G3P2L2 woman presents in her third trimester with vaginal leaking. On PV examination, the anterior lip of the cervix can be palpated. In the given clinical scenario, the uterus is anteverted as the anterior lip of the cervix was palpable. The round ligament helps maintain the anteversion of the uterus during pregnancy. However, the anteversion in the non-pregnant uterus is maintained by both the uterosacral ligament and round ligament. Next case is a multiparous woman presented with a urethrocoele due to weakness of the urogenital diaphragm. The urogenital diaphragm is also known as triangular ligament. The urogenital diaphragm extends from the pubic arch anteriorly to the central point of the perineum posteriorly and consists of two layers of fascia through which pass the vagina and urethra. The central point of female perineum lies between the vagina and the rectum. Urogenital triangle presents between two ischiopubic rami, which stretches transversely across the rami. There are three membranes. From above downwards, the membranes are as follows: superior fascia of urogenital diaphragm, inferior fascia of urogenital diaphragm, and membranous layer of superficial perineal fascia. The uterine cavity is lined by a single layer of ciliated columnar epithelium. The wall of the uterus consists of three layers, that is perimetrium, myometrium, and endometrium. Perimetrium is the serous coat adherent to the underlying muscle. Myometrium consists of thick bundles of muscles that form three distinct layers during pregnancy, that is outer longitudinal, inner circular, and middle interlacing called living ligature. Endometrium is the mucous lining of the cavity. It consists of lamina propria and surface epithelium, which is a single layer of ciliated columnar epithelium. During ovulation, the thickness of the endometrium is around 11 mm. Immediately after menstruation, endometrial thickness is 1 to 2 mm. In early proliferative phase, endometrial thickness is 5 to 7 mm. In secretory phase, it is 7 to 16 mm. In pre-ovulatory phase, it is up to 11 mm. In post-menopausal phase, it is less than 4 mm. In post-menopausal, that means in case of abnormality which requires biopsy, endometrial thickness will be more than 4 mm. The uterus is innervated by the fibers of the uterovaginal plexus, which is also known as the Frankenhauser ganglion. Round ligaments receive their blood supply from Samson's artery, which represent the anastomosis of the uterine artery and ovarian artery. The cardinal ligaments are also called transverse cervical ligament or McEnroe ligaments. They consist of perivascular connective tissue. They attach to the posterolateral pelvic walls near the origin of the internal iliac artery and surround the vessels supplying the uterus and vagina. Lymphatic drainage of the uterus is primarily to the obturator and internal and also external iliac nodes. One theory of endometriosis states lymphatic spread as cause for seeding in the pelvis. Next case is a gynecologist is performing a hysterectomy. She accidentally nicks the ureter in the ureteric canal as it pierces the McEnroe's ligaments. In this case, the uterine artery above and uterine venous plexus below are likely to be damaged here as the ureter is present between these vessels. The ureter pierces the McEnroe's ligament forming the ureteric canal. In this canal, the ureter is crossed by the uterine artery above and the uterine plexus of veins below, thus being present in between the uterine vessels. The ureteric canal provides the necessary room for normal peristalsis without pressure from surrounding structures. After leaving the ureteric canal, the ureter passes forwards and medially to reach the bladder. It is 1 to 2 cm away from the cervix. Next case is, you take a culture swab from the portio vaginalis of a woman having foul-smelling vaginal discharge. Portio vaginalis or exocervix is the other name for the vaginal part of the cervix. Cervix is the lowermost part of the uterus extending from the histological internal os to the external os. It is cylindrical in shape, measuring 2.5 cm in length and diameter. Cervix is made up of 10% muscle and the rest is collagen, elastin and proteoglycan. The lining of the cervix has the following parts, that is exocervix, endocervical glands as well as transformation zone. Exocervix is also known as portio vaginalis. It is lined by non-keratinized stratified squamous epithelium. Endocervix, it is lined by high columnar ciliated epithelium. Endocervical glands secrete alkaline mucus. When enlarged, they form swellings called Nabothian follicles or cyst. Transformation zone is the epithelium gradually changes from columnar to squamous in this region. The cervix is to corpus ratio before puberty is 2:1. The relationship between the length of the cervix and that of the body of the uterus varies with age. Before puberty, cervix is to corpus ratio is 2:1. At puberty, it is 1:2. At reproductive age, it is 1:3 or 1:4. After menopause, it is 2:1. However, the uterus and cervix are both atrophied. The Gardner's duct is a remnant of the Wolffian duct in women. These are located in the broad ligament and the vagina. The duct can sometimes form a cyst in the broad ligament or in the vagina. It is called Gardner's cyst. It is a benign condition and can be treated with marsupialization. Contents of broad ligament include one tube, that is one fallopian tube, two ligaments including round ligament of uterus and ovarian ligament, two arteries including uterine artery and ovarian artery, 2 nerve plexuses, that is uterovaginal plexus and ovarian plexus, 3 embryological remnants, that is ipoophorone and paraophorone and Gartner's duct. Ipoophorone is the Wolffian body, paraophorone is the Wolffian body, Gartner's duct is Wolffian duct. Other structures are lymph vessels and lymph nodes and also fibrous connective tissue. The ovarian ligaments are contained in the posterior fold of the broad ligament. The broad ligament contains the following parts, that is mesosalpinx as well as mesometrium. Mesosalpinx lies between the fallopian tube and ovarian ligament. It contains the pelvic vessels which anastomoses between uterine and ovarian arteries. The ovary is attached via ovarian ligament through the posterior folds to the mesoovarium. Mesometrium contains the ovarian vessels within the infundibulopelvic ligament. The ureter is present in the inferomedial part of the broad ligament. It is related to the uterine artery here and may be damaged during hysterectomy. Broad ligament is not a support of the uterus. Peg cells are seen in the fallopian tubes. A peg cell is a non-ciliated epithelial cell within the fallopian tube. These cells are also known as intercalated or intercalary cells whose function is not yet known. Next is about fallopian tube. The fallopian tube is divided into the following parts. They are intramural or interstitial portion, isthmus, ampulla and infundibulum. Ampulla is the longest and widest part. It is the most common site for fertilization and ectopic pregnancy. Isthmus is the most common site for tubectomy. Intramural or interstitial portion is intrauterine and it is the narrowest and shortest part. The longest and widest part of the fallopian tube is ampulla, which is 5 cm. Histology of fallopian tube includes the ampulla, isthmus and infundibulum, which are extrauterine. They are covered by 3 layers. They are mesosalpinx, myosalpinx as well as endosalpinx. Mesosalpinx is the peritoneal layer, which is also called as serosa. Myosalpinx contains smooth muscle and has 2 layers, that is inner circular as well as outer longitudinal. Endosalpinx is the mucosal layer. It has the following features, that is numerous branching folds filling the entire lumen, basement membrane, ciliated columnar epithelium, peg cells, that is non-ciliated epithelium. They also help in the capacitation of sperms. Tunica albuginea of the adult ovary is derived from the subepithelial connective tissue layer. Structure of the ovary includes surface epithelium, subepithelial connective tissue layer, parenchymatous zone, and zona vasculosa. Surface epithelium is a single layer of cuboidal cells which is present, which later gives rise to the surface epithelium of the adult ovary. It is morphologically continuous with the mesothelium of the peritoneum. The subepithelial connective tissue layer gave rise to the tunica albuginea of the adult ovary and basement membrane beneath the surface epithelium. The parenchymatous zone becomes the cortex and contains the egg nest and ovarian follicles. Zona vasculosa becomes the medulla and contains blood vessels. Hilar cells present here are homologous to interstitial cells of testis. They can rarely produce hilar cell tumors of the ovary. Next case is, during the histopathological examination of an ovarian mass, Kohl-Exner bodies are seen. Kohl-Exner bodies are formed by granulosa cells present within the granulosa cell layer of the ovary. They are small, distinctive, gland-like structures filled with acidophilic material resembling immature follicles. They are characteristically seen in granulosa cell tumors of the ovary. Graafian follicle is spheroidal or ovoid in shape. The mature graafian follicle contains pent-up secretion known as the liquor folliculi. The lining consists of theca externa, theca interna, which contain the theca cells, granulosa cell layer, cumulus ophorus. Cumulus ophorus, we can see projection of granulosa cells into the cavity of the graafian follicle. It is also called discus proligerus. The efferent preganglionic sympathetic fibers to the ovary are derived from T10 to T11. The ovary is supplied by sympathetic and parasympathetic nerves. The ovarian plexus consists of postganglionic sympathetic fibers, preganglionic parasympathetic fibers from the sacral outflow, and visceral afferent fibers. The ovarian plexus has the following parts, that is upper part from the branches of renal and aortic plexus, lower part from the superior and inferior hypogastric plexus. Rupture of spiral arteries causes bleeding during normal menstruation. This is a branch of uterine artery. The blood supply of the uterus is as follows, that is uterine artery, arcuate artery, radial artery, basal artery, spiral artery. Next case is a uterine artery embolization is being planned for a patient with uterine fibroids. In this given case scenario, blood flow in the vaginal artery will not be affected as it is not a branch of uterine artery. The vaginal artery is a branch of anterior division of internal iliac artery. It is homologous to the inferior vesical artery in males. It supplies the vagina and the base of the bladder in women. It should not be confused with vaginal branches of the uterine artery. Branches of the uterine artery include ureteric branch, vaginal branch, that is descending vaginal branch. These unite to form the anterior and posterior azygous arteries of the vagina. Next branch is circular cervical branch. Next is Samson's artery, which runs in under the round ligament. Samson's artery represents the anastomosis of the uterine artery and ovarian artery. Next branch is arcuate artery, radial artery, basal artery, spiral artery, and straight arterioles of the functional layer of the endometrium. Next case is a patient with stress incontinence required surgical management. While performing a Bursch-Kolpow suspension, the surgeon approached the space of Retzius. The space of Retzius is the other name for prevesical or retropubic space. Bursch-Kolpow suspension is a procedure done to relieve stress urinary incontinence. If an extraperitoneal approach is selected, the retropubic space is entered by perforating the transversalis fascial layer of the anterior abdominal wall. Once the retropubic space is dissected, the bladder neck and the vaginal fascia underneath are identified. The bladder is mobilized to the opposite side. At each side of the bladder neck, 2 to 4 preferably non-absorbable sutures are placed in the space of Retzius. The presacral space is a retroperitoneal space that lies between the peritoneum of the posterior abdominal wall and the sacrum. It contains the superior and inferior hypogastric plexus. The sacral sympathetic trunk lies against the sacrum's ventral surface. Germ cells appear in the yolk sac in the third week. The sequence of events in primordial germ cell formation and migration are: at second week, germ cells are formed in the epiblast. At third week, germ cells move through the primitive streak and migrate to the wall of the yolk sac. At fourth week, germ cells begin to migrate from the yolk sac to gonads. At fifth week, germ cell migration is complete. Gametes are derived from these primordial germ cells. The ovary contains the maximum number of oogonia at the 5th month of intrauterine life. The number of oogonia is estimated to be 7 million. Oogenesis is the process wherein oogonia differentiate into mature oocytes. It begins before birth. At birth, there are approximately 2 million primordial follicles. At the initiation of puberty, the follicle count is less than 4 lakh, of which less than 500 are destined to ovulate. Every month, 15 to 20 follicles are released, out of which one matures to form the ovum. Next case is a man with oligospermia has completed his course of hormonal treatment. The sperm count is tested 70 to 80 days after hormonal treatment, as the average time taken for spermatogenesis is 74 days. Spermatogenesis is the process of formation of sperms from spermatogonia. Approximately 100 million sperms are produced daily. In patients diagnosed with oligospermia, hormonal treatment is carried out using FSH, HCG, or testosterone. Improvements in sperm count can take a few months, hence the course is usually for 3 to 6 months. Normal spermatogenesis occurs after this time period. Spermiogenesis refers to the series of changes that occur for the formation of spermatozoa from spermatids. These are acrosome formation, condensation of nucleus, formation of neck, middle piece and tail, shedding of cytoplasm as residual bodies. Complete motility is obtained in the epididymis. The time taken for the capacitation of sperm is 6 to 8 hours, approximately 7 hours. Sperms have to undergo 2 changes in the female reproductive tract to be able to fertilize the ovum, that is capacitation as well as acrosomal reaction. Capacitation is the functional maturation of the spermatozoa. It occurs in the fallopian tube and involves epithelial interaction between the sperm and the mucosal surface of the tube. The glycoprotein coat and seminal plasma proteins are removed. Only capacitated sperms can pass through the corona cells and undergo the acrosomal reaction. Acrosomal reaction occurs after binding to zona pellucida induced by zona proteins. Enzymes such as acrosin and trypsin-like protein are released to penetrate the zona pellucida. Calcium plays an important role. Meiosis 1 in the primary oocyte is resumed after LH surge. Meiosis 1 or reductional division occurs in the transition from primary spermatocyte to secondary spermatocyte. Meiosis takes place in germ cells to generate male and female gametes. Meiosis involves two stages of cell division, namely meiosis 1 and meiosis 2. Meiosis 1 produces two haploid cells because the ploidy is reduced from diploid to haploid. Meiosis 1 is referred to as a reductional division. Meiosis 2 is an equational division analogous to mitosis, resulting in the creation of four haploid daughter cells. The secondary oocyte is formed after meiosis 1. Primordial germ cells divide by mitosis to form oogonia. The majority of the oogonia divide by mitosis, however, some enter meiosis 1 and get arrested in the diplotian stage of prophase and are now called primary oocytes. Primary oocytes have not completed meiosis, hence they are diploid. The primary oocyte, along with surrounding epithelial cells, form the primordial follicle. Meiosis 1 is completed after LH surge during puberty to form the secondary oocyte. Next case is an embryologist is preparing embryos for implantation. In this case, zona hatching occurs at around 5 days after fertilization. Fertilization is divided into the following phases, that is penetration of the corona radiata, penetration of the zona pellucida, fusion of the oocyte and sperm cell membranes. After fertilization, the zygote differentiates to form the morula and then the blastocyst. The zona pellucida disappears at this stage, which is called zona hatching. The trophoblast, which is the outer cell mass, are now able to associate with the endometrium during implantation. Next case is you are performing intrauterine insemination during the ovulatory period in a patient with infertility. In this case, the fertilized ovum implants by 6 to 10 days in the uterine cavity. Implantation involves apposition, adhesion, and invasion. Apposition is initial contact of the blastocyst to the uterine wall. Adhesion is increased physical contact between the blastocyst and uterine epithelium. Invasion is penetration and invasion of syncytial trophoblast and cytotrophoblast into the endometrium. A successful implantation requires receptive endometrium primed with estrogen and progesterone released by the corpus luteum. Next is time after fertilization and its events. Less than 24 hours, zygote is formed and cleavage begins immediately. Within 2 to 3 days, 5 to 8 cell stage is done. Within 3 to 4 days, stage of compaction and formation of morula with 16 cells is formed. 4 to 5 days, formation of blastocyst. Within 5 to 6 days, zona pellucida disappears. Within 6 to 7 days, implantation of the blastocyst. At 9 days, bilaminar disc formation is seen. At 12 days, there is formation of extraembryonic mesoderm. Implantation occurs 6 to 7 days after fertilization. After implantation, the endometrium is called decidua. It is of the following types. They are decidua basalis, decidua capsularis, decidua parietalis. Decidua basalis present over chorion frondosum. Decidua basalis and chorion frondosum form the placenta. Decidua capsularis is present over embryonic pole. Decidua parietalis is present over the opposite side of the uterus. The villi cover the entire surface of the chorion during the early weeks. As the fetus grows, villi on the embryonic pole continue to grow, giving rise to the chorion frondosum. At the embryonic pole, the villi degenerate. By the 3rd month, this side of the chorion becomes smooth and is called chorion leve. As the fetus grows, the chorion leve comes into contact with the decidua parietalis on the opposite side of the uterus and fusion occurs. Thus, the uterine lumen is obliterated. The amnion and chorion fuse to form the amniochorionic membrane. Rupture of the amniochorionic membrane during labor is called breaking of waters. Superfetation can theoretically occur till the time the uterine lumen is not obliterated. Langhans cells form the cytotrophoblast. The cells of the blastocyst differentiate into an outer trophectoderm and an inner cell mass. The trophectoderm is further differentiated into an inner mononuclear cellular layer called cytotrophoblast or Langhans layer made of Langhans cell. An outer layer of multinucleated syncytium called syncytiotrophoblast is also seen here. The blastocyst further divides to form the morula. Primary oocytes are the germ cells seen in the medullary region of the ovary. These enlarge at the beginning of the growth phase. During this cell growth period, many oocytes undergo degeneration, both before and after birth. A single layer of flattened follicular cells that were derived originally from the germinal epithelium soon surrounds the primary oocytes. The structure that is formed is now called primordial follicle. These are seen first in the medulla and later in the cortex. Fertilization usually occurs in the ampulla of the fallopian tube. During ovulation, the ovum is released and it enters the fallopian tube. It is propelled towards the uterine cavity by the peristaltic action of the fallopian tube. It can only be fertilized within 24 hours of ovulation. If coitus takes place during this period, the spermatozoa swimming up into the tubes meet the ovum in the ampulla. Next case is a newborn is admitted to NICU with oropharyngeal teratoma which contains derivatives from all three germ layers. The tumor may include gut, bone, skin and teeth. These tumors arise from pluripotent stem cells that differentiate it into any of the three germ layers forming tissue of all three germ layers, that is endoderm, ectoderm and mesoderm. The posterior wall of the yolk sac forms the allantois on 16th day of development. Its distal portion forms the urachus which forms the median umbilical ligament. Next is pediatrics. First question, the WHO states that the perinatal period commences at 22 completed weeks and ends at 7 completed days after birth, that is 154 days. It corresponds to when the fetus weighs 500 gram or more. This definition is not to be confused with the period used for calculation of the perinatal mortality rate. To calculate the perinatal mortality rate, a fetal weight above 1000 gram is considered, which is achieved at 28 weeks of gestation. Therefore, for all statistical purposes, international comparisons and calculation of perinatal mortality rate, the period from the 28th week of life is considered. Perinatal period is from the 22nd week. Perinatal mortality rate calculation is from the 28th week. The neonatal period is defined as the first 28 days after birth. Infancy is defined as the first year of life. A very low birth weight baby is one whose birth weight is less than 1.5 kilogram. They are often premature, that is less than 37 weeks of gestation. A low birth weight baby is one whose birth weight is less than 2.5 kg. An extremely low birth weight baby is one whose birth weight is less than 1 kg. Post-term infants are those born after 42 completed weeks of gestation as calculated from the mother's LMP regardless of weight at birth. Next is a case. Reena, a 34-year-old lady with gestational diabetes mellitus, delivers an LGA baby at 37 weeks. Infants with birth weight greater than the 90th percentile for their gestational age are called LGA babies, that is large for gestational age babies. Maternal diabetes and obesity are predisposing factors for LGA babies. They have a higher incidence of birth injuries, that is cephalohematomas, brachial plexus injury, phrenic nerve injury, and others are hypoglycemia, polycythemia, and congenital heart disease. Next case is, as the intern assisting in the labor room, you are tasked with administering vitamin K to the term newborn with no complications. All newborn infants are to be administered vitamin K at a dose of 0.5 to 1 mg intramuscularly to prevent hemorrhagic disease of newborn. However, for newborns with vitamin K deficiency, the dose of vitamin K administered is 1 to 5 mg intravenously. Next case is a term neonate born by normal vaginal delivery is diagnosed with hypothermia. Neonates do not generate heat by shivering. Heat production in neonates happens by increasing the metabolic rate and oxygen consumption by releasing norepinephrine, which results in non-shivering thermogenesis through beta oxidation of brown fat. This sympathetic surge also causes cutaneous vasoconstriction. Increased physical activity like crying, increased body movements and muscular activity also contribute to thermogenesis. Preterm and small for gestational age infants have scanty brown fat stores. Next case is you are conducting the routine newborn assessment of a 2.3 kg baby born 10 minutes back. You would classify the neonate as having cold stress if you notice the body temperature to be 36 to 36.4 degrees Celsius. A temperature of 36 to 36.4 degrees Celsius categorizes a neonate as having cold stress. An infant's normal body temperature is 36.5 to 37.5 degrees Celsius. It is measured in the apex of the baby's axilla by holding the thermometer for at least 3 minutes. Hypothermia is an axillary temperature of less than 36.5 degrees Celsius. Cold stress is 36 to 36.4 degrees Celsius. Moderate hypothermia is 32 to 35.9 degrees Celsius. Severe hypothermia is less than 32 degrees Celsius. Hyperthermia is an axillary temperature of more than 37.5 degrees Celsius. Next case is a 24-year-old primigravida delivers a preterm baby at 33 weeks of gestation with a birth weight of 2 kg. She is advised to hold her child as position of kangaroo mother care. Kangaroo mother care can be carried out by the mother or any other caregiver. Kangaroo mother care was introduced for the prevention of neonatal hypothermia in low birth weight or premature newborns. It has 4 components. They are skin to skin positioning of the newborn on the mother's chest, adequate nutrition through breastfeeding, early discharge and ambulatory care, support for mother and family for child care. Evidence shows that it is at least equivalent to incubators in terms of safety and thermal protection, that is, when measured by mortality. This reduces severe morbidity by way of facilitating breastfeeding, humanization of neonatal care, and promoted bonding between mother and child is seen here. Eligibility criteria for KMC is it is indicated for all hemodynamically stable low birth weight babies. Short sessions of KMC can be initiated in babies on medical treatment like IV fluids or oxygen therapy. Initiation of KMC can vary with the birth weight of the baby. That is, if the birth weight is less than 1200 gram, it may take days to weeks for initiation of KMC. If birth weight is 1200 to 1800 gram, only a few days may be taken before KMC initiation. If birth weight is more than 1800 gram, KMC can be initiated immediately after birth. All mothers without any serious illness can provide KMC. Positioning for KMC is the baby is placed between the mother's breast in an upright position. The hips are abducted and flexed in the frog position and the arms are also flexed. The abdomen of the baby should be at the level of the mother's epigastrium. In this position, the mother's breathing would stimulate the baby and prevent the development of apnea. The duration of KMC should be gradually increased from short sessions of more than 1 hour to 24 hours a day. KMC is not necessary once the baby attains 2500 gram of weight or 37 weeks of gestation. Incubatory care, feeding via nasal catheter, and prevention of infection are part of intensive care for low birth weight babies. The lowest score on the expanded new Ballard score is -10, which corresponds to 20 weeks of gestational age, and the highest score is 50, that is 50, which corresponds to 44 weeks of gestational age. An increase in the score by 5 points corresponds to an increase of 2 weeks of gestational age. Scarf sign is a component of the neuromuscular criteria for maturity according to the expanded new Ballard score. Scarf sign is if the infant's arm is pulled medially across the chest. In an hypotonic infant, the elbow will cross the midline. In a term infant with a normal tone, the elbow will not reach the midline. Neuromuscular criteria for maturity according to the expanded new Ballard score is posture, square window that is wrist, arm recoil, popliteal angle, scarf sign, and heel to ear. Palmar surface is not a component of the physical criteria for maturity according to the expanded new Ballard score. Physical criteria for maturity according to the expanded new Ballard score is skin, lanugo, eye or ear, plantar crease, not palmar surface, plantar crease, and breast and also genitals. These are the physical criteria for maturity according to expanded new Ballard score. Next is a case. While examining a healthy term neonate, you notice that the baby passes greenish black colored stools, which is due to biliverdin. Meconium is a dark, sticky material that is normally present in the intestine at birth and passed in the feces after birth. It is detected in the ileum at about 70 to 85 days of fetal life and begins to fill the colon and lower ileum late in the 4th month of gestation. The greenish color of the meconium is the consequence of the bile pigments excreted by the biliary tract. The main component responsible for the greenish color of the meconium is biliverdin, which is a pigment formed from the oxidation of bilirubin. Up to the 22nd week of gestation, the intestinal content is not greenish, and for this reason, fetal defecation would not stain the amniotic fluid. The production of biliverdin starts over the next few weeks or at a time closer to labor, probably due to a biochemical switch related to the bilirubin oxidation system. Bilirubin is responsible for the yellow color of the stools. Neonates do not harbor gut flora at birth. The parachute reflex has its onset at 7 to 8 months of age. It is fully developed by 10 to 11 months of age and remains throughout life. It can be evoked by holding the infant's trunk and then suddenly lowering the infant as if he or she were falling. The arms will spontaneously extend to break the infant's fall. This reflex is prerequisite to walking. Palmar grasp onset is 28 weeks of gestation. Rooting reflex onset is 32 weeks of gestation. Moro reflex onset is 28 to 32 weeks of gestation. Tonic neck reflex onset is 35 weeks of gestation. Parachute reflex onset is 7 to 8 months postnatal. Next case is a 6-day-old infant is being examined. While checking the reflexes, a brisk Moro's reflex is noted. A brisk Moro reflex can be seen in neonates with hypoglycemia. In hypoglycemic babies, there is an activation of the autonomic system which results in jitteriness. Newborns often exhibit this as an exaggerated Moro reflex. The Moro reflex is a primitive reflex that is very sensitive to the infant's level of alertness. It is elicited by supporting the infant in the semi-erect position and allowing the infant's head to fall backward onto the examiner's hand. Normal response to Moro's reflex is symmetrical extension and abduction of the upper extremities followed by flexion of the upper extremities. The Moro reflex disappears by 6 months of age in normal infants. Absent Moro reflex is caused by significant generalized disturbance of the CNS like Kernicterus and also stage 3 HIE. HIE is hypoxic ischemic encephalopathy. Next is asymmetric Moro reflex. It is a feature of the root plexus or nerve disease like brachial plexus injury or Erb's palsy, fractured clavicle, and also in hemiparesis. Brisk Moro reflex is seen in stage 1 HIE. It can also be a normal variant in healthy infants, and brisk Moro reflex is also seen in neonatal hypoglycemia. Exaggerated stereotyped non-habituating Moro reflex is a feature of severe bilateral intrauterine cerebral disturbance, perhaps because of the release of the brainstem from inhibitory cortical influences. It is seen in conditions such as hydranencephaly, severe microencephaly. Next is Moro reflex in different stages of hypoxic ischemic encephalopathy. There will be brisk Moro reflex in stage 1 HIE, that is mild HIE, stage 2 HIE, that is moderate case. Here there will be weak or incomplete Moro reflex. In stage 3 HIE, that is severe case, there will be absent Moro reflex. In Kernicterus, there is a deposition of unconjugated bilirubin in the basal ganglia and brainstem. Hence, the Moro reflex is absent. In stage 3 HIE, the muscles are flaccid and the infant is comatose. Thus, the Moro reflex is absent. Erb's palsy results from an injury to brachial plexus, so the reflex is absent on the side of injury as the nerve supplying the muscles involved is affected. Asymmetric tonic neck reflex, that is ATNR. Asymmetric tonic neck reflex disappears by 4 months postnatally. The tonic neck reflex is produced by manually rotating the infant's head to one side and observing for the characteristic fencing posture, that is extension of the arm on the side to which face is rotated and flexion of the contralateral arm. An obligatory tonic neck response in which the infant becomes stuck in the fencing posture is always abnormal and implies a CNS disorder. Asymmetric tonic neck reflex is a primitive reflex. Generally, all primitive reflexes hinder voluntary movements. That is, till a newborn has ATNR, it is difficult for the infant to hold the object in both hands towards the midline. Hence, the disappearance of ATNR is when the infant can grasp objects in the midline, and this which usually occurs between 4 to 5 months. Next case is a first-time mother rushes to the OPD with her 4-day-old infant and worriedly points to the rash that appears in the body. You reassure her of its harmless transient nature. On microscopic examination, these papular lesions on an erythematous base will reveal eosinophils. The given clinical complex describes a case of erythema neonatorum. Right stain smear of the contents of the pustule will show an abundance of eosinophils. They are papular lesions on an erythematous base distributed over the trunk and face predominantly. They are seen 1 to 3 days after birth and may persist for up to a week, after which they resolve spontaneously. Neutrophils are seen in pustular melanosis. Next is benign findings in a newborn. It includes erythema toxicum, which is a small white papule on an erythematous base that usually present on the face, trunk and extremities. They contain eosinophils and may persist for a week. Next is Mongolian spots. It is a slate blue demarcated areas of pigmentation seen over the buttocks and back. This is also called dermal melanocytosis. Next is pustular melanosis. It is a benign lesion seen predominantly in black neonates, contains neutrophils and is present at birth as vesiculopustular eruption around the chin, neck, back, extremities, palms and soles. Next is sebaceous hyperplasia. It is a white yellow papule on nose of a newborn due to hyperplastic sebaceous glands. Next is melia. It is a pearly opalescent white epidermal inclusion cyst usually over the face. Next is Epstein pearls. It is a nest of epithelial cells that appear as whitish or yellowish spot on hard palate. Usually it resolves by 3 months. Next is cutis marmorata. It is a transient lacy reticular vascular pattern of skin caused due to exaggerated physiologic vasomotor response on exposure to low environmental temperature. Next is sucking blisters. It is solitary or scattered superficial bullae present at birth on the upper limbs of infants, which is caused by vigorous sucking on the affected part in utero. Next is salmon patch or nevus simplex. It is a small, ill-defined, pink-colored macules commonly seen over glabella, eyelids, upper lip and nuchal area, which develop due to vascular ectasia. Next is harlequin color change. It is a transient, well-demarcated color change with one half of the body displaying erythema and the other half pallor, usually occurring between 2 and 5 days of age. Next is vaginal bleeding in the newborn at 2 to 3 days of age and enlargement and secretion of the breast in both sexes. Next is hymenal tags. Next is physiological phimosis, conjunctival hemorrhage, peeling of skin especially in post terms. These all are benign findings in a newborn. Mongolian spots, which is also known as dermal melanocytosis, are benign blue or slate grey macular lesions with clearly defined margins that appear over the presacral region, which is most common, and also it is seen in posterior thighs, legs, back and forearms. These spots occur due to the presence of melanin containing melanocytes in the dermis, which is arrested during the migration from neural crest cells to the epidermis. They are non-tender and do not rapidly change in color or size. Next case is a male infant born at 34 weeks of gestation by emergency LSCS was found to have a finding on histopathological examination of umbilical cord which showed two vessels, that is a thin walled umbilical vein and a thicker walled umbilical artery. The presence of a single umbilical artery which is associated with an increased risk for an occult renal anomaly. The normal umbilical cord contains two arteries and one vein. A single umbilical artery is the most common cord abnormality. Anomalies are seen in 30% of the cases with a single umbilical artery. The incidence is higher in twin deliveries. Trisomy 18 is a common association. Next case is, on a particularly busy day in the labor room, you are requested by the PG to take anthropometric measurements and calculate the pondral index of a baby while she attends to another baby. You find the pondral index to be 1.45. A pondral index of less than 2 suggests asymmetric intrauterine growth restriction. Asymmetric IUGR is associated with a brain sparing effect, unlike symmetric IUGR where there is no sparing of head growth. Pondral index equal to birth weight in grams divided by length in centimeter cube into 100. It is a weight height related parameter used as an indicator of fetal growth status. In detail about the symmetric IUGR, insult on fetal growth occurs early, head circumference, length and weight are equally affected. A pondral index greater than or equal to 2 is seen here. Symmetric IUGR is caused by genetic chromosomal disorders or torch infections. In detail about the asymmetric IUGR, insult occurs in late gestation, relative sparing of brain growth is seen. A pondral index less than 2 is seen in asymmetric IUGR. Asymmetric IUGR is caused by placental insufficiency, pregnancy-induced hypertension, or maternal medical diseases. A pondral index of 1.75 suggests intrauterine growth restriction. Gestational diabetes usually presents with fetal macrosomia. Maternal factors associated with IUGR are hypertension or renal disease, diabetes with placental vasculopathy, hypoxemia, malnutrition, chronic illness, sickle cell anemia, drugs like narcotics, alcohol, cigarettes, cocaine, maternal infection, and parasite infestations. Next case is, an unbooked primigravida with no antenatal records delivers a 2.5 kg male baby by normal delivery. While ascertaining the maturity of the child, which of the following would be against a diagnosis of prematurity? Answer is thick ear cartilage. Detail about this case: thick cartilage with a stiff ear in a newborn is a sign of maturity, that is, the baby is not premature. Score 0 is pinna flat and stays folded, no recoiling. Score 1 is slightly curved pinna, soft and slow recoiling. Score 2 is well curved pinna with soft but ready recoiling. Score 3 is formed and firm, instant recoiling. Score 4 is thick cartilage and ear is stiff. No creases on the sole, insignificant breast nodule, and empty scrotum are all physical signs of prematurity in a newborn. Abundant lanugo hair is not discriminatory evidence of prematurity. This is because neonates of diabetic mothers born as a term or even post-term have abundant lanugo hair, especially over the pinna and upper back. Next case is, a lady with wrong dates and a corrected gestational age of 43 weeks presents with labor pains. The CTG suggests placental insufficiency and she is taken up for emergency LSCS. The physical sign of an infant born post-term, that is 43 weeks, in association with presumed placental insufficiency is abundant hair, that is not scanty hair. Infants born post-term in association with presumed placental insufficiency may have various physical signs, together termed as post-maturity syndrome or dysmaturity syndrome. These include desquamation, pale skin and long nails, loose skin around the thighs and buttocks, meconium-stained nails, skin, vernix and umbilical cord, presence of placental membranes. Next case is, a 34-year-old lady with an obstetric score of G3P2L2 delivers a baby boy at 43 weeks plus 2 days period of gestation. In this case, anemia is not a complication of post-maturity. Polycythemia may be seen in neonates born after 42 weeks of gestation. Complications of post-maturity include perinatal depression, meconium aspiration, hypoglycemia, hypocalcemia, polycythemia, persistent pulmonary hypertension. Next case is immediately following vaginal delivery, a baby is noted to have a diffuse ecchymotic swelling on the scalp. Caput succedaneum is a diffuse, sometimes ecchymotic edematous collection of serosanguinous fluid in the subcutaneous layer of the scalp, involving the presenting part in a vertex delivery. It may extend across the midline and crosses suture lines. Cephal hematoma is a subperiosteal hemorrhage that is always limited to the surface of one cranial bone and does not cross suture lines. The swelling appears only several hours after birth. There is no discoloration of the overlying scalp. Subgaleal hemorrhages occur with the rupture of emissary veins, which connect the dural sinuses with the superficial veins of the scalp. Blood accumulates between the epicranial aponeurosis of the scalp and the periosteum, which resolves over 2 to 3 weeks, often associated with vacuum assisted delivery. Next is epidural hemorrhages, usually traumatic in origin and is associated with cephalopelvic disproportion, prolonged labor, breech, precipitous labor, or which occur as a result of mechanical assistance in labor. Majority resolve with no intervention. Next in detail about caput succedaneum and cephal hematoma. Caput succedaneum is seen in the presenting part of the head. It is seen immediately after birth. Cause of caput succedaneum is prolonged labor causing venous stasis and edema. Extent of movement of caput succedaneum is it is seen in both hemispheres which crosses the suture line. Period of absorption is 2 to 4 days. There is no treatment. Next is cephal hematoma. It is seen in the periosteum of skull bone and bone. Time of appearance is several hours after birth. Cause of cephal hematoma is instrumental delivery which causes rupture of emissary veins in the skull. Extent of movement of cephal hematoma is individual bones which do not cross the suture lines. Period of absorption of cephal hematoma is 2 weeks to 3 months. Treatment of cephal hematoma is supportive treatment. It can cause neonatal jaundice. Cephal hematoma is a subperiosteal hemorrhage that is always limited to the surface of one cranial bone and does not cross suture lines. The swelling appears only several hours after birth. There is no discoloration of the overlying scalp. Most cephal hematomas are resolved within 2 weeks to 3 months depending on their size. Cephal hematomas require no treatment, although phototherapy may be necessary to treat the associated hyperbilirubinemia, that is resorption of blood which takes place by the breakdown of RBCs. Next case is a baby in the postnatal ward is noted to have paralysis of the left hand along with ipsilateral ptosis and meiosis. Left-handed paralysis with ipsilateral ptosis and meiosis in a newborn suggests a diagnosis of Klumpke's paralysis associated with Horner syndrome. There is an injury to the 7th to 8th cervical nerves and the 1st thoracic nerve. This produces a paralyzed hand where the intrinsic muscles of the hand, that is T1, and the ulnar flexors of the wrist and fingers, that is C8, are mainly affected, and the baby lies with the forearm supinated and the elbow flexed. There may be a unilateral Horner syndrome characterized by ipsilateral ptosis and meiosis if the sympathetic fibers of the first thoracic root are also injured. Next is about Erb Duchenne paralysis. It affects the 5th and 6th cranial nerves. There is a loss of abduction of the shoulder, external rotation and supination. Morose reflex is absent on the affected side. Next is phrenic nerve palsy, that is it affects the 3rd, 4th and 5th cranial nerves which results in diaphragmatic paralysis. It is characterized by cyanosis and irregular labored breathing. Next is Horner syndrome. It is characterized by meiosis, ptosis, enophthalmos, anhidrosis and loss of ciliospinal reflex. Next case is following a delivery complicated by shoulder dystocia, the baby is noted to have a deformity in the right upper limb. On inspection, the orthopedic JR notes an adducted, internally rotated arm and a pronated forearm. The clinical vignettes suggest a diagnosis of Erb Duchenne paralysis. The injury is limited to the 5th and 6th cervical nerve roots. The characteristic position consists of adduction and internal rotation of the arm with pronation of the forearm. There is a loss of abduction of the shoulder, external rotation and supination. There is an asymmetric Morose reflex seen here. In shoulder dystocia, the most common nerve injury is to the C5-C6 nerve root. The most common bone to fracture is the clavicle. Next case is a term infant develops jaundice at day 2 of life. It first appeared on the sclera and progressed to the trunk by day 4. It completely disappeared by day 7 following phototherapy. The above pattern of jaundice is suggestive of physiological jaundice or icterus neonatorum. It is due to increased bilirubin production from the breakdown of fetal red blood cells combined with transient limitation in the conjugation of bilirubin by the immature neonatal liver. It first appears on the second or third day, usually peaks on the fourth day at 5 to 6 mg per deciliter and decreases to less than 2 mg per deciliter between the 5th and 7th days after birth. Rh incompatibility between maternal and fetal red blood cells lead to pathological jaundice. Next case is a male infant with a birth weight of 3.2 kg is admitted to phototherapy unit with a total bilirubin of 11 mg per deciliter at 36 hours of life. Jaundice associated with a rise in bilirubin level at a rate of less than 5 mg per deciliter per 24 hours suggests physiological jaundice. Features suggestive of pathological jaundice are jaundice appears within the first 24 hours after birth, jaundice presents at or beyond age 3 weeks or sick infant, elevated direct or conjugated bilirubin level, total serum bilirubin level above the expected normal range, jaundice seen in the mid-abdominal region that is equal to 15 mg per deciliter and in salts it is equal to 20 mg per deciliter. And other features suggestive of pathological jaundice are total serum bilirubin concentration not responding to phototherapy, total serum bilirubin rising rapidly that is crossing percentiles in an infant receiving phototherapy. Next case is the peripheral smear of a newborn baby girl sent on day 2 of life shows mild hemolysis. ABO incompatibility is the most common cause of hemolytic disease of newborn and affects the firstborn. It is usually mild and subclinical. This incompatibility between the mother and fetus generally results in milder disease than Rh incompatibility does. It arises when a mother with blood group type O becomes pregnant with a fetus of different blood type that is A or B. The mother's serum contains naturally occurring anti-A and anti-B which can cross the placenta and cause hemolysis of fetal RBCs. Although antibodies against A and B factors occur without previous immunization, that is through natural antibodies, they are usually IgM which do not cross the placenta. However, IgG antibodies to A antigen may be present and these do cross the placenta resulting in AO isoimmune hemolytic disease in the firstborn infant. AO is more common than BO. Next case is a 3.3 kg term neonate is admitted on day 3 of life with yellowish discoloration of the skin. The most effective wavelength of light for phototherapy in neonatal indirect hyperbilirubinemia ranges from 460 to 490 nanometer, that is blue-green light. Clinical jaundice and indirect hyperbilirubinemia are reduced by exposure to the high intensity of light in the visible spectrum by 3 mechanisms. They are photooxidation, which is the minor method, reversible photoisomerization reaction, which converts toxic unconjugated bilirubin into an unconjugated configurational isomer. It is then excreted in bile without conjugation. Next is irreversible structural isomerization, which is the most important mechanism which acts by forming lumirubin from native bilirubin. It is then excreted by the kidneys in the unconjugated state. Blue-green light, which has a wavelength of 460 to 490 nanometer, is more effective than blue light, which has a wavelength of 430 to 470 nanometer due to the following reasons. That is, blue-green light preferentially favors the formation of lumirubin. Its longer wavelength enhances skin penetration. Pure blue light can mask cyanosis in an infant. Phototherapy is effective only when bilirubin is accumulated in the skin. There is no role of prophylactic phototherapy in mild or subclinical jaundice. Contraindication of phototherapy is porphyria. Next case is a mother noticed yellowish discoloration of her term newborn within the first 6 hours of life. On examination, jaundice extended up to the lower abdomen and thighs. SN mesoporphyrin, that is SNMP, a synthetic metalloporphyrin, is a potential alternative medical therapy for pathological jaundice in neonates. It acts by competitive inhibition of the conversion of heme protein to biliverdin by heme oxygenase. A single intramuscular dose on the first day of life reduces the need for subsequent phototherapy. Complication from metalloporphyrins includes transient erythema if the infant is receiving phototherapy. Tolazolin is an alpha adrenergic antagonist that produces systemic and pulmonary vasodilation, which is used to correct the pulmonary artery vasospasm when it causes severe right-left shunting soon after birth. Tromethamine is an organic buffer used in the management of metabolic acidosis. Next case is, while on rounds in the postnatal ward, the senior PG shows you a baby with dark greyish brown skin discoloration. It is a term AGA baby on day 7 of life. She tells you that it is a case of bronze baby syndrome. The bronze baby syndrome is a dark greyish brown skin discoloration in infants undergoing phototherapy. It mainly occurs in infants with direct hyperbilirubinemia as an adverse effect of phototherapy. Despite the bronze baby syndrome, phototherapy can continue if needed. Other complications of phototherapy are loose stools, erythematous macular rash, the purpuric rash associated with transient porphyrinemia, overheating, dehydration, hypothermia from exposure. Grey baby syndrome is an adverse effect of chloramphenicol. Red man syndrome is an adverse effect of vancomycin. A 3.2 kg term neonate is born to a primi gravida with gestational diabetes. Periodic monitoring of blood glucose is being done. The cutoff for the treatment of neonatal hypoglycemia is a plasma glucose level of less than 45 mg per deciliter. That is, blood glucose should be less than 40 mg per deciliter. This is particularly applicable after the initial 2 to 3 hours of life. Babies showing plasma glucose less than 45 mg per deciliter on a reagent strip should be treated for hypoglycemia. Since reagent strips have high false positive rates, a confirmation of hypoglycemia by a lab test is recommended. Neonatal hypoglycemia includes plasma glucose less than 45 mg per deciliter and blood glucose less than 40 mg per deciliter. Next case is, after the delivery of an infant of a diabetic mother, the blood glucose of the infant was 60 mg per deciliter. Serum calcium should be estimated in this baby to rule out hypocalcemia. Infants of diabetic mothers are at high risk of developing hypoglycemia, hypocalcemia, hypomagnesemia. Hypocalcemia is defined as a total serum calcium concentration of less than 8 mg per deciliter for a term baby and less than 7 mg per deciliter for a preterm baby. It is thought to be caused by lower parathyroid hormone concentrations after birth in infants of diabetic mothers as compared to normal infants. Higher serum ionized calcium concentrations in utero may suppress the fetal parathyroid glands. Next case is, a 31-year-old lady with diabetes mellitus delivers a term neonate. Infants born to diabetic mothers may present with macrosomia, which is large for gestational age, hypocalcemia and neural tube defects. That is, I will repeat the same sentence. Infants born to diabetic mothers may present with macrosomia, hypocalcemia and or neural tube defects. Other common features include hypoglycemia, respiratory distress syndrome, cardiomegaly, heart failure, cardiac malformations like VSD, ASD, transposition of great vessels, which is the most specific, truncus arteriosus, double outlet right ventricle, tricuspid atresia, coarctation of aorta, lumbosacral agenesis. Additional anomalies include neural tube defects, hydronephrosis, renal agenesis and dysplasia, duodenal or anorectal atresia, situs inversus, double ureter and holoprosencephaly.